Good morning, everybody. Welcome here. I'm just gonna give it a second for folks to come on into the room. Good morning. Hello. Okay, welcome. My name is Sherry Lissy Sickerson, and I am your moderator for this morning's session for the Rapid Access to Addictions Medicine Knowledge Exchange Days. You will note that there is a question box located at the top of your panel. If you have any questions regarding this presentation, we will be answering them towards the end of the session. We have the last few minutes tagged for answering questions, so that's great. Just type them in and we'll get you some answers at the end of the session. What I'm going to do now is turn the mic over to Tina Leclerc, who is our host for this session, and she will be introducing our speakers for today. So thank you again, everyone, for joining us. I'm really looking forward to this session.
Thanks, Sherry. Welcome, everyone, to today's session. I'm pleased to introduce our presenters for today, Caroline Gahungu. Caroline is a master's in social work, serves as a manager of health services, clinical specialist, mental health nurse educators, and BRACT within Mental Health and Addictions program at Shared Health Manitoba. She provides strategic direction in provincial planning, development, and coordination of specialized clinical programs and services that strengthen mental health care across Manitoba. Based in Winnipeg, Caroline is an active collaborator within provincial mental health networks, working closely with clinicians, educators, policymakers, and system partners to enhance access, quality, and consistency of care. During Manitoba's wildfire response, Caroline also served as an operational lead, supporting coordinated emergency and mental health response efforts across the province. And our second presenter today is Lori Ulrich. Lori is a registered nurse and serves as the Director of Health Services, Crisis Services, Rapid Access to Addiction Medicine, Intake and Coordination within Shared Health, Mental Health and Addiction. Lori provides strategic oversight for the Winnipeg Crisis Response Services and Provincial Intake Services. As a registered nurse with extensive experience in emergency, remote health care, and mental health, Lori has worked both urban and northern communities across Manitoba and Nunavut. Under her leadership, Shared Health expanded and modernized its crisis response continuum, including the implementation of virtual and integrated stabilization supports. Her work reflects a deep commitment to safety, accessibility, and collaborative mental health system design, which enabled her to provide flexible responses to the Manitoba wildfires as one of the operational leads. So Caroline, I believe you're in presenter mode, so thank you very much. Folks, sit back, enjoy the presentation, and if you have questions, please enter them in the question box. Thanks.
Thank you, Tina, for that warm welcome. Good morning, everyone, and thank you for attending today's session. As you all are aware, this year was an unprecedented wildfire season in Manitoba. Tens of thousands of people were displaced from their home communities, families leaving with belongings of what they could carry, arriving in unfamiliar cities, and facing uncertainty of not knowing when they could return or what life would look like when they did. Impacts of displacement compound the trauma that has been inflicted upon our relatives for centuries. This image illustrates the long journey via bus and plane entire communities in the north made to Winnipeg and other areas of our province to escape the fires. Throughout the response, I was inspired by the strength of community spirit of our relatives and community leaders. I was heartened by the commitment of first responders, volunteers, and service providers who worked tirelessly throughout the response. There were also many lessons learned from this experience. For some, this topic may bring up difficult emotions, and I encourage you to please take care of yourself during this session. I'd like to begin with a statement of acknowledgement of Indigenous, ancestral, and territorial lands. Health services across Manitoba are provided in facilities located on the original lands of First Nations, Inuit, and on the national homeland of the Red River Métis Nation. Manitoba's health authorities respect that First Nation treaties were made on these territories, acknowledge harms and mistakes, and we dedicate ourselves to collaborate in partnership with First Nations, Inuit, and Métis peoples in the spirit of reconciliation. Health services across Manitoba are provided in facilities located on the original lands of First Nations, Inuit, and the national homeland of the Métis Nation. Oh, and we, there's a little bit of a duplication here, my apologies. Today, I'm going to provide an overview of shared health, mental health, and addictions wildfire response, highlight key partnerships in our collective efforts, identify the pathways that were developed to support Manitobans access timely mental health and addiction supports, and highlight lessons learned for the future. This presentation was prepared by myself and Lori Ulrich, Director of Crisis Services. We both served as operational lead for the 2025 Shared Health, Mental Health, and Addictions Wildfire Response, in addition to Arlene McLennan. I'd also like to acknowledge contributions for this presentation from our partners at Southern Health Santé Sud, Prairie Mountain Health, and the supporting work of Northern Regional Health Authority, especially during repatriation efforts. So just in terms of our outline for today, we're going to cover the background and context of the wildfire season, our response, including the incident command structure and broader system efforts, local Winnipeg response, and the mental health and addictions care pathways, review important considerations and lessons learned, and also share some key takeaways from our provincial partners. We'll focus on repatriation efforts, and then we'll have time at the end for questions and discussion. So first, I'll start by talking about some of the background and context for this presentation. And so for context, this image was taken by the Manitoba government of the wildfire near Flin Flon on May 27th, and this shows the magnitude of the fires in our province this year. For many years, we have collaborated on a provincial level to respond to natural disasters. So this includes floods and wildfires, but what was different this year was the scale. So the number of communities impacted and the length. The wildfires began early in the season and were met with unfavorable weather conditions, and this led to out of control spreading. This is a timeline to set the context for today's presentation. The wildfires in Manitoba's east and south were raging when the northern fires broke out. On May 28th, Manitoba declared a state of emergency due to 22 active wildfires with nearly 200,000 hectares of forest and land already burned, three times the 5-year average. The following day, on May 29th, evacuations were ordered for 17,000 people in northern and eastern Manitoba, including the city of Flin Flon in Winnipeg. And in Winnipeg, the Canadian Red Cross led the response with support from the province's emergency social workers to stand up a staging reception areas in multiple congregate sites as people arrive via bus and plane. The Manitoba wildfire map in the left image is dated May 31st, with red representing out of control fires. In many cases, the fires were dangerously close, which underscores the serious risk which this posed to entire communities. So with communities evacuated, core services were stood up at sites, including Indigenous-led organizations such as MKO and Turtle Team, public health primary care, and mental health and addiction supports. Red Cross worked to transfer our relatives to hotels where possible. However, the volumes exceeded the number of hotel rooms in the province. On June 23rd, the province lifted the state of emergency, with some communities being able to return home. However, on July 10th, Manitoba declared another province-wide state of emergency as wildfires continued to threaten communities and new evacuation orders were issued. Communities like Snow Lake were evacuated for the second time this summer. On August 23rd, the state of emergency was lifted, although some communities such as Leaf Rapids, Lynn Lake, and Marcel Colomb First Nation and Pucktawagan did not return until September as crews worked to restore hydro. In summary, the 2025 wildfire season saw 32,000 Manitobans flee their homes and communities. So this image shows the Canadian military deployed to support evacuation of entire remote communities. In Winnipeg, Billy Mosienko was the initial staging and reception center. Congregate sites in Winnipeg included Leela Soccer Plant Complex, University of Winnipeg Rec Center, Century Arena, Red River College, and the RBC super site. So this was for a large number of individuals who were evacuated. Later, Billy Mosienko was repurposed to provide culturally based and trauma-informed supports to individuals with substance use support needs, which I will discuss later on. So talk a bit about shared health response specifically. The incident command structure is a standardized management framework that can be activated at any time, not only during wildfire season, but it can be applied across all levels of the health system. It provides structured support to sites and regions by coordinating response and recovery activities for all types of major emergencies and disasters. An effective incident command structure enables a coordinated, efficient, and accountable response. So here you see a chart, and it shows how shared health, mental health, and addictions fit into the larger picture. It's important to note, though, that this is not a fully inclusive incident command structure, but wanted to illustrate, when we go to the next slide, what our response was. Additional key roles included Chief Medical Officer, Health Service Integration and Quality, Diagnostic Services, Patient Flow, Emergency Response Services, Community Health Services, Long-Term Care, Primary Care, Cancer Care. So many other programs and services were also members and part of the command structure. Within shared health, mental health, and addictions and incident command structure, you can see the main roles and various partners we collaborated with to support a coordinated and rapid response. Beyond this structure, within Winnipeg, the various site leads and managers and frontline staff, along with many other services, serve critical on-the-ground roles to provide timely mental health and addiction supports to individuals, both at the reception center and the congregate sites. So this is a colorful slide, but why I wanted to show this is that it really demonstrates and highlights all of the services that worked collaboratively to support individuals and were involved in the response. And so this is the Winnipeg specific mental health and addiction services map. And it was a living document, and it offered a comprehensive overview of the mental health and addiction services and supports predominantly available to our relatives in Winnipeg. And here you can see it visually represents the coordinated response across the system and aiming to clarify the access points. So through those different lines and see how we're all connected to streamline the care journey for those impacted by the fires. It also underscored the commitment of all partners involved to provide timely, accessible, and compassionate care, recognizing the unique stressors and traumas that wildfire displacement can create. By presenting this coordinated system, we aim to ensure that all service providers in our network had a clear roadmap to navigate the available resources effectively. At that time, there was also ongoing work to support individuals located outside of Winnipeg through the Provincial Mental Health and Addiction Incident Command Table, and I'll talk more about the work of our regional partners in upcoming slides. Here you'll see on the left-hand side of the map depicts the hotels with congregate supports. The top box shows the congregate or evacuation site supports, and the middle box with the orange and the purple depict the reporting and escalation levels. You will also see the Indigenous advisors and the specialized supports available. On the right top hand box where the legend is, it's color coded. That also you'll see then matching it to the boxes identifies many of the key partners involved in the response, including Indigenous-led organizations, grant-funded agencies such as Canadian Mental Health Association and CEREL, to emergency social services and beyond. In addition to on-the-ground support, Shared Health in collaboration with our partners created and shared various tools, handouts, and resource guides to support our relatives and service providers during the response. Tools for Manitobans experiencing the wildfires, including individuals from Flin Flon, relatives from First Nation communities, and then also tools for healthcare providers. So examples of tools for individuals included on the left-hand side, the handout available at the wildfire sites, and there were various handouts like these, and coping after a stressful event resource document. The health services and resource guide was a service navigation tool for providers. A resource guide for clinicians was also developed, and this was to provide guidance on how to support individuals impacted by the wildfires. Sessions were also held for healthcare professionals, recognizing the added stress of the wildfire season and providing supports for navigating this time. These were facilitated by Shared Health Wellbeing Hub and Clinical Health Psychology. So I'm going to focus now on the Winnipeg response. The Winnipeg response involves standing up our incident command structure and establishing key partner linkages, so with our Indigenous leaders, Red Cross, emergency social services, scheduling regular incident command tactical meetings, assessing our current state, which is important, going to the different sites and understanding what was needed, and establishing an initial response plan. There were a lot of different logistics to sort out, gathering resources and supplies, creating operational binders and resource binders, and a staff orientation plan so that staff were aware of what their roles were when they arrived at the sites. We also worked to identify, mobilize, and deploy frontline staff to sites, and also worked to develop the role of the site lead or manager to provide support and oversight for the work that we were doing. We also wanted to ensure that we were responsive and flexible and in order to meet the needs in the moment. And so we would scale up or scale down the response depending what was happening, and also refining our documents, our response plan, our operational procedures and resources. And so within a few days of when the wildfire response began at the end of May, we had established a staffing model for 12 hours a day at the reception center and all congregate sites, working shoulder to shoulder with WHA to deploy frontline mental health and addiction staff. I'll talk a bit about the frontline roles at the sites. Mental health and addiction staff role at both the reception and congregate sites during both phases was to provide psychological first aid. And for many of you who are familiar with psychological first aid, this is an evidence-informed modular approach to help children, families, and adults in the immediate aftermath of a disaster. So on the right-hand side, you'll see this reference card, and that was a tool that was used as part of staff orientation. There are 5 key principles of psychological first aid: creating a sense of safety, calming, a sense of self and community efficacy, connectedness, and hope. The core actions of psychological first aid include contact and engagement, being proactive and using factual questions, checking in, offering a more private area to chat, and what we did was applying a loitering with intent strategy, so making sure that we are accessible and available. Safety and comfort is extremely important, meeting basic needs, validating and normalizing reactions, offering snacks and refreshments. And so this is where you really think about the Maslow's hierarchy of needs. We also, at the beginning, were addressing basic needs like gathering diapers and formula for families and actively circulating at the sites. Stabilization is another key component. We did this through offering support and non-judgmental listening. Information and gathering is another phase, which includes assessing current needs and concerns. And so this is looking at what is needed, encouraging individuals to share, really listening through a trauma-informed lens, and also identifying what the themes were so that that information could be brought forward to look at addressing needs on a larger scale. Practical assistance is another area where we worked with various services, including our Indigenous-led partners and Department of Families, to develop children's area and support, transportation, nutrition, And so here we, as I mentioned, we liaise with on-site services quite a lot to provide practical assistance. We also look to connect with social supports, suggesting natural and community supports. And we liaised heavily with fantastic Indigenous-led turtle team and spirit teams to ensure that relatives had access to culturally safe care and support. When I had mentioned earlier some of the handouts that we provided, this is consistent with psychological first aid, and that providing information on distress reactions and coping is another key area, which validates reactions and building on what has helped the person in the past, recognizing that these are normal experiences to abnormal events, and being trauma-informed, recognizing that some of these communities had been displaced as well during previous other wildfires or floods and may bring back traumatic memories. We linked with collaborative services, and this included also medical services or traditional mental health services. And so just a little bit about the spirit team, because I really want to highlight the important role that they had, as well as the turtle team. The spirit team stands for Support and Protect Indigenous Relations Intervention Team, and they are comprised of helpers and action-oriented therapists and healers, and they served as an important liaison between government services, the Red Cross, partnering agencies, and our relatives. And certainly we worked closely with the spirit team throughout the response. They provided trauma-informed interventions, and this included de-escalation support, resource provision and connection, and creation of safe spaces. They worked in collaboration as well with the Assembly of Manitoba Chiefs, Mamaway, and engaged in supportive counseling and in addressing and filling gaps in existing services. Their turtle team was a team from the First Nations Health and Social Secretariat of Manitoba. This was an Indigenous team dedicated to providing essential wraparound supports for First Nation relatives who found themselves away from home due to the wildfires. They provided cultural support, advocacy, family support, and child and youth support. There are various operational considerations that we had to take into account in the response. And as operational lead, there were many different logistics of standing up the response quickly, but then also sustaining the response. We also pulled staff from existing operations and then had to look and problem solve about ways to maintain normal operations. As I mentioned, we had a collaborative staffing model with the Winnipeg Regional Health Authority. We worked to coordinate scheduling, the shift length, the location, description of the roles, and ensuring that the frontline staff had support and oversight by the on-site lead. It was important for us to be nimble and responsive in the face of this fast-changing environment, which was a challenge at times. But that was really important to us so that we could really adjust and adapt our response to what was needed in the moment. And we also worked heavily to ensure accessibility and procedures to harm reduction and safer use supplies, no lock zone kits, and training for administration. We also worked to address safety concerns for staff and individuals as they emerged over the course of the response. So now I'll spend a bit of time talking about the mental health and addictions care pathways. And this involved a lot of collaboration and coordination with our service partners. The primary goal in creating pathways to care was consistent with the no wrong door approach, ensuring that frontline staff and service partners could assist individuals with accessing services to best meet their needs. We ensured connection and follow-up for individuals who required support to make sure that no one was falling through the cracks. It was important to find creative solutions, knowing that our current services and resources were already stretched. And so we did this by linking into existing pathways and looking to prioritize and develop contingency plans. We communicated these pathways to frontline staff, site leads, and our service partners. And despite creative approaches, we did find that there were still some challenges, which I'll talk about in a moment, but also included as these processes included required referrals to ensure that the service could meet the individual's needs, there were some wait times. And so this was an issue that we were consistently trying to work through. And so here you will see different service partners, including RAAM, MOST, the Crisis Response Center, Detox. So this also included not only Mainstream Project, but for those individuals that required more medical support, the Addictions Unit, and treatment beds through Bruce Oak, Behavioral Health Foundation, Tamarack. And then we also liaise with urgent care and emergency departments, particularly when there are high acuity needs, including withdrawal. And so I'll talk a little bit about our pathways into existing services, RAAM, MOST, and CRC with Crisis Response Center first. So what we did here was we actually had a single point person, and so referrals to MOST and RAAM, our service providers could actually contact the managers directly, which is a different way of accessing services, but we wanted to make sure that there weren't challenges. Folks were coming to Winnipeg, may not have been familiar with the city or services, wanted to ensure that our services were low barrier, and so we had an on-call manager where these services could contact the manager directly to facilitate contact with service and book appointments. For individuals who required OAT, but had, so if they were on OAT and they were in Winnipeg but had no resource to provide it, arrangements were made through MOST and the Four Arrows Regional Health Authority. This also included clinics in Winnipeg where relatives could get their injections, and new starts were also being arranged through the RAAM clinics. If the person was from Garden Hill, they would be referred to MOST nurses who were providing Sublocade in the community in Winnipeg or Garden Hill. And then for the Crisis Response Center, the Shared Health, Mental Health, and Addiction Site Lead could contact the clinical team lead directly to coordinate services and arrange for transfer to CRC for assessment. So for individuals who are at the reception or congregate sites who needed this support and more assessment was required, they could liaise directly with the CTL. The frontline staff, as I mentioned in site leads, also liaise with the hospitals and emergency departments. Next, I'll talk about detox. So I'll focus more on Main Street Project. So there was a need for a pathway to Main Street Project detox beds. And what we did was, again, linking into existing services. But through this, we were able to prioritize access for our northern relatives. The point person in this case was, again, a single person, the RAAM manager, and the process included that the service providers could identify the individual who was interested or wanting detox. The individual could attend the CRC RAAM clinic for assessment and referral. And what we saw were many successes is that there were many consults and collaborative care planning that occurred, and individuals through this way were connected with appropriate services. There were some challenges. Again, this was a one person who was on call throughout the response. At times, the acuity of the individuals was too high to go to MSP detox. So we had to look at other options through, for example, HSC Addictions Unit. This also meant there were fewer Main Street Project beds for RAAM clinics. And there was referral, as I mentioned, was still a process. So it did sometimes take a couple of days to ensure that the individual could be appropriately treated at Main Street Project. In terms of treatment beds, talking about Bruce Oak first. Those was actually new pathways that were created in a relatively short period of time with our community partners for individuals who are interested in accessing a treatment bed in Winnipeg. And so this, through various meetings and collaborations with Bruce Oak leadership, led to a streamlined referral form that was developed by Bruce Oak to be completed by the Shared Health, Mental Health, and Addiction staff for either a spot in their in-house day program or in-house program. The process was that the staff at the congregate sites or one of the partner agencies could let the mental health and addiction site lead know that a relative was requesting a referral to a treatment bed. And that information was then promptly passed on to the MOUSE manager, who would contact the individual and agency requesting collateral information for the referral, and then would follow up through phone with the individual to complete the referral. Once that was done, if the individual was still interested in the treatment bed, then Bruce Oak would complete the intake and the admission. Similar process occurred for the Behavioral Health Foundation, and they agreed to prioritize evacuees for treatment beds. So the process was relatively similar, and that the information was passed on to the MOUSE manager. They would contact the individual requesting that collateral information, and then Behavioral Health Foundation would then complete the intake and admission. Tamarack Recovery Center was a little bit different in that they provided the information to support relatives in Winnipeg. They provided low barrier access, and so what they had done is provided direct access, provided that number to us that we were able to share to the intake coordinator, so that they could we could discuss and send information about relatives who required their assistance, so we could do that directly. Our response then also included working at Billy Mosey & Co Arena, and this was phase 2 when it was repurposed as a person-centered harm reduction approach. So through this, at this site, supported relatives who may not have been successful in other congregate sites due to substance use needs, mental health distress, or trauma-related behaviors. The goal of Billy Mosey & Co Arena was to provide low-barrier, culturally safe environment where individuals could stabilize, connect with supports, be treated with compassion. And so information as well about Billy Mosey & Co Arena was also provided and shared during the November 19th presentation on the Garden Hill experience. So Billy Mosey & Co was led by the Department of Housing, Addictions and Homelessness, and worked closely with Nadinaway Mac. And this site operated using a community support model, which was an informal community-led approach with a variety of service providers. And this really ensured that the support was culturally safe and trauma-informed, really heavily relying on a harm reduction approach. If a relative was identified at a congregate site that would benefit from the Billy Mosey & Co site, the site lead would speak with a relative and then make arrangements for them to go to Billy Mosey & Co. At the site, the different components included a welcoming approach. There was TP and fire that would welcome relatives to the site, cultural practices, ceremonies, nutrition, rest, and access to safer use supplies, and a naloxone for overdose prevention. Here we would also link with medical supports and services, provide crisis support and de-escalation, and really important to meet people where they're at. So if they were requesting a referral to detox or treatment bed, we would facilitate that, but that certainly was not an expectation. Again, at Billy Mosey & Co, consistent with a harm reduction approach, staff were trained and all services to recognize that here substance use was expected and that support was unconditional. And so again, this was really consistent with the approach of meeting individuals where they're at and providing that safe environment and focus on relationship building. There were many different documents that were created to orient staff to ensure that the approach was consistent with the intention of this site. And this included the practice service delivery manual. I'll talk a little bit about the congregate sites to the hotel response. So in addition to the congregate sites, there was also many different mobile teams that worked in the hotels as part of the response during the wildfires. It was important that we had linkages from the congregate sites and reception center to the hotels. We liaised heavily with Sarah Rial and Canadian Mental Health Association and the Canadian Red Cross Mental Health and Psychosocial Support Team, mobile team. We collaborated with the Turtle Team, Spirit Team, Assembly of Manitoba Chiefs, and MKO. Through this time, we also developed a shared space where we would have regular touch points that focused on child and youth needs. Again, there were various service partners where we came together on a regular basis, recognizing that there may be individuals or families with young children with complex needs, and so developed a referral form so that individuals and families that were interested in services could be directly connected to those services. And so those services were within shared health, mental health, and addictions in our child and youth treatment program. There is also a shared health, mental health, and addiction site lead, as I mentioned, at the sites, but they also remained as an available clinical resource to the mental health and addiction services throughout the response. Just want to spend a moment talking about some important considerations as well as challenges that we experienced during the response. We certainly saw that there was stigma around substance use, and we know that stigma still exists, and this was no different during the response. And so through this, we had to really work hard to make sure that there was accessibility of harm reduction and safer use supplies and create a sense of safety for relatives at the sites. There are various concerns that emerged and that were addressed through increased safety measures and security measures to ensure that the environment was safe for individuals and families. And this was due to risks of gang activity, drug dealing, and exploitation at the sites. I also wanted to mention again that the impacts of displacement are traumatic, and this also included out-of-province evacuations. And this was necessary due to hotel shortages, but if you can imagine having to leave your community and then also now having to go to another province, so completely, an unfamiliar setting, and not knowing when you're going back can be pretty traumatic. And so this was really important and for us to keep in mind throughout the entire response. Even people that had come to Winnipeg, we had heard that some people had never left their home community, and so being in a busy city was a huge adjustment for some individuals. And so really keeping that front and center as we work to provide support. We also recognize that with some high needs for mental health and addiction support, there were associated withdrawal and overdose risks. This is certainly not an exhaustive list of the challenges we experienced, but wanted to highlight some of them. The availability and drug supply used in the community was perhaps different than in Winnipeg. Here in Winnipeg, we know that they're more likely to substances to be mixed with other substances, and the accessibility of these substances increase the risk. So this is something that we had to keep in mind. We also experienced limited privacy at the sites and transportation challenges from sites to other services. The need for improved documentation of clinical interventions, which we addressed throughout the response and worked to develop these mechanisms. But as the response was protracted over a long period of time, also recognizing the need for more resources for children and families, and then the ongoing challenge of keeping up to date with a rapidly changing environment and on the immediate and emerging situation. As I mentioned, the response was prolonged, and so through this we worked to navigate how we would maintain our normal operations and staff scheduling and heavy workloads, and working to be mindful of the risk of burnout for our staff. Some key takeaways that we learned throughout the response was the importance of Indigenous-led response, really recognizing the importance of Indigenous and traditional ways of knowing, practicing cultural humility. We also saw that when we connected with the Turtle Team and Spirit Team, that relatives were more likely to approach them. And so when we were closely connected between our services, it led to positive outcomes. And I really want to highlight that because I think that was a critical piece in this response. We also saw the value and received feedback from all our partners about the how it was helpful to have regular tactical huddles. This involved allowed us to have regular communication between each other, be aware of emerging needs, plan and problem solve as things arose. There was a lot of collaboration and coordination with our partners, including our grant-funded agencies here in the city. As we kind of look to the potential for the future, it was really important that we have a response in the future where we can take what we have done and lessons learned to just develop a response plan that will enable us to seamlessly scale up or down our response. And so we learned a lot from this experience. There are various other takeaways, but here are some of the main ones. I'm going to spend a few moments talking about regional responses, and this was a province-wide effort. Southern Health was another key player, and they saw over 800 evacuees over the course of both phases. This was through their response. They had central coordination hub that was initially established at the Kennett Inns with hotel beds and a cot-based venue. They had multiple hotels in the area that were utilized in both phases. They had mental health and addiction services that were on site daily to support individuals. And their coverage began with 24-hour presence and later transitioned to 5 to 10 hours of daily on-site support. This also included when we partnered with them because within Shared Health, Mental Health and Addictions, we have a youth program out in Southport, so partnered with them to provide staffing. So these are some of the services provided. So similar to Winnipeg response, assessment intervention, crisis intervention, de-escalation support, psychological first aid and emotional support, access to addiction medicine and consultation, and linkages to local community. And then again, the importance that within psychological first aid of really addressing those general and basic daily needs. The key takeaways shared by Southern Health was that there was strong collaboration around multiple internal health sectors, such as public health, primary care, and home care. They had effective partnerships with Indigenous-led organizations and First Nation communities, specifically Southern Chiefs Organization and Long Plains First Nation. Through these identified leads, they were instrumental in enhancing support and aiding in ensuring culturally safe environments. They also, in Southern Health, they had a flexible and responsive staffing model, and this allowed to rapidly adjust to evolving needs. And the team presence on site increased the visibility and accessibility of the supports. So similar to Winnipeg, there were also challenges. No designated lead from Canadian Red Cross. So the Department of Families assumed a lead role. This led to some challenges in terms of coordination, communication gaps. There was also an absence of a common communication platform to document interventions. So this is actually a takeaway that we're working on as well in terms of documentation protocols in the event of a provincial emergency such as this. Difficulty maintaining continuity of care and information sharing across multiple partner systems and daily scheduling at times was cumbersome. Prairie Mountain Health also had a significant response, and I'll talk by start by talking about the brand and response. So this was a reception center that was established by the Canadian Red Cross. The Southern Chiefs organization had set up a resource center, and the mental health and addiction staff were coordinated with SDO throughout the evacuation until mid-September. The mobile team so with the SDO mobile team and the mental health and addiction team shared information on individual needs. SDO also had a hotel-based response or resource center and served as a central hub. This was a new level of coordination compared to previous evacuations, which included positive collaboration and improved overall response. Again, they found that individuals were more likely to approach SDO staff, and so the connection between these organizations increased the likelihood of positive connections. In Dauphin, no initial reception site was planned, but the West Region Treaty 2 and 4 Health Services led their response. They established a reception center, and the staff delivered psychological first aid and support 7 days a week at the reception center. Although addiction support was limited, they did make positive connections through addiction medicine and ensuring that individuals could access sublocate treatment through RAAM or the primary care outreach clinic. Key takeaways from Prairie Mountain Health included strong collaboration, consistent daily presence at the sites, individuals were more likely to connect with the hotel rounds than at the reception centers. They also had some difficulties with the staffing model similar to other regions, and also recognized the importance and value of paraprofessionals that they could bring, and so something to consider for the future. Last, I want to talk about repatriation pathways, and this was really important when considering supports when returning home. Stress of the communities being displaced and concerns raised when you think about people coming to a new environment, that can increase stress for individuals and can result in new or increased substance use support needs. We had many meetings and correspondence with communities to learn about the needs and share information. Some examples include repatriation pathways work for Split Lake, Leaf Rapids, and Lynn Lake. Through this process, Northern Regional Health Authority was crucial at sharing, as well as Shared Health, at sharing information on services, resources, and pathways. These services included the RAAM and Digital Front Door, NADAP, in-house and community addictions programs, Shared Health virtual crisis services, and virtual CSU, to name a few. Information was developed and shared with communities to raise awareness of existing pathways to both Northern Regional Health Authority and provincial services. With appreciation for the significant system-level response and many important lessons learned along the way, I want to recognize the swift actions, effort, and enormous hard work of everyone involved in the response, including service providers offering on-the-ground support. We remain cognizant of the impact these traumatic events have had on our relatives, not only from the fires, but the effects of cumulative trauma and how these situations can bring up traumas of the past. Keeping this front of mind informed the how of our work, and remembering to always lead with care and compassion first. So I just wanted to share, this is a recent photo of my family. Many of you may have seen the Northern Lights recently in Winnipeg. And I thought this image just depicted an important time for us as the colder weather comes upon us to pause and reflect on the past number of months and identify actionable ways we can improve upon for the future. Our leadership team here at Shared Health Mental Health and Addictions has actively embarked in this process. We've summarized feedback from various debriefing exercises, and we are engaged in planning to support future readiness should this occur again in the future. So at this time, I just want to thank everybody for taking time out of your morning to attend this session. We would welcome any questions or comments at this point.
Okay, so I'm looking at questions. So first of all, Caroline, thank you so much. And that picture at the end was just beautiful. So there is a question here. Thank you for your presentation. What efforts are being made to apply what we have learned to future wildfire responses?
So we are right now just finalizing the debriefing sessions, and so within the senior leadership team, there have been various meetings to look at what we can do and how we can improve in the future. So through those debriefing meetings, there's been a summary of those findings. I know that there is work to develop a response package so we can take all of the things that we've learned and apply them for the future. There's also other pieces that we need to address, like documentation practices, naloxone training for staff, and so those are just a few. So those have led to other projects that are now underway. Lori, do you want to, if there's anything I've missed, feel free to color that in.
Yeah, I think, thanks, Caroline. And I think one of the big things you've mentioned is just writing things down in the package that you mentioned. So there was so many things that we learned, and we received so much really valuable feedback from providers at all different levels and all different areas that they were working in. And so actually documenting some of these learnings and processes so that we can pull this out and hit the ground running should this unfortunate event occur again.
Okay, there's another question. So was there a need for French services, and how did you address that?
I don't believe that was a need, but if it was a need, we certainly would address that through collaboration with French language services. We have access to those resources, and we would definitely tap into that. So if that became a need, or we suspected that would be a need, we would collaborate with French language services.
And one last question before I pass it over to Tina for wrap up. Will these slides be made available?
Sure, I can make them available and send them to the RAAM team here for distribution. Happy to.
Perfect. So I'm just going to pass it over to Tina to wrap things up.
Sure. Thanks, everyone. I think that the session is recorded and will be posted on Shared Health, Mental Health, and Addiction webpage under RAAM Knowledge Exchange 2025. So if you want to kind of review it at your leisure, you can see the slides in the recorded presentation on our website. So that's another option. Thank you again for taking time out of your schedules today and hearing about the enormous work that happened over the summer to support Manitobans through what was a very difficult time. Having spent time in the congregate sites myself, the resiliency that was displayed from our relatives, from our northern communities, was just amazing. Thank you, Caroline. Thank you, Lori. And I wish everyone a really good day.